Good morning, well, afternoon now, and welcome to the Delta Research and Educational Foundation Research Matters for All of Us second event for October. As I think most are aware, October is Breast Cancer Awareness Month. So why are we here and talking about breast cancer? 1 in 8 women in their lifetime will develop breast cancer, and for men, 1 in 1,000. Breast cancer has the highest death rates of any cancer for women ages 20 to 59. African American women have a 31% mortality from breast cancer, which is the highest of any racial group. We know that those women at less than age 45 are diagnosed with breast cancers that are significantly aggressive, often called triple negative breast cancer. So we are here today to talk about breast cancer awareness. I will first talk a little bit about the Research Matters campaign, and then I will turn it over to our guest speaker for the day. I bring you greetings. My name is Yvonne Collins, and I am the Chicago Citywide Coordinator for the Delta Research and Educational Foundation Research Matters for All of Us. And again, I welcome you today. The All of Us Research campaign is a research campaign identified and funded by the National Institutes of Health. As you can see on this slide, this is our core team that is working diligently to ensure our part of the project, which is to educate the African American community on the importance of biomedical research and clinical trials, a lot of which you will see today. These are the 12 cities chosen by the National Institutes of Health. And each month we put on 2 webinars, given the pandemic, where we attempt to educate the community on various subjects. That is why you'll hear about breast cancer awareness today. Let's listen a little bit about the campaign.
So much of what we've done in medicine over the years has not really taken into account individual differences. And this is an opportunity to be part of something historic.
Most studies and most clinical trials have always been with the average white male. So as we start thinking about this in the context of building trust, I think we get back that trust by involving the community. Not saying you come to us or we'll just do things to you. We're going to do things with you and in fact allow that information to be accessible to you, the individual.
You're going to have some individuals that are going to say, yes, good, we're getting in on the ground level of a study. And then you're going to have those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input, and without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened. We're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that, whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer or heart disease. Communities of color are disproportionately impacted by them.
It has always been playing catch up to make sure that they're even getting access, much less minimum service. Low income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who is never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
So the NIH All of Us research program is really historic. It aims to engage 1 million members from diverse populations with the goal to improve healthcare outcomes and decrease healthcare disparities. It's really a catalyst of what we now talk about as an individualized approach to the prevention and treatment of diseases called precision medicine. And let's hear what President Obama has to say about precision medicine.
Something called precision medicine, in some cases people call it personalized medicine, gives us one of the greatest opportunities for new medical breakthroughs that we have ever seen. Doctors have always recognized that every patient is unique. And doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? What if figuring out the right dose of medicine was as simple as taking our temperature? And that's the promise of precision medicine, delivering the right treatments at the right time, every time, to the right person.
And so the mission of the All of Us research program is to accelerate research. We saw it in the midst of COVID pandemic with the COVID vaccination, so we know it can be done. The other mission is to nurture relationships. That is the relationships between the community and science, between the community and academic centers, between disproportionately affected populations and scientists. It's really to deliver the richest and largest biomedical research that we have ever seen. Again, the accrual of 1 million disproportionately affected minorities. What are the core values of the program? Well, it's open to anyone, but our focus today is the African American population. We encourage diversity. We encourage partnership. We encourage transparency. That is, anybody who participates in the program or scientists that are involved in the program understand exactly what's being done. It's an access broadly to your data. This is not a program where your data is taken and you never hear anything about it. Really, the goal of this research program is to take all of that data that we have on you, your biometrics, your family history, your personal history, the kind of medications you're on, the environment you live in, and then be able to create therapies that focus on you. All of that information is secure and private, all with moving toward a positive change in medicine. What happens when participants participate in the trial? Well, it's a very easy enrollment and consent process. If you are part of a facility that already has an electronic medical record, those are merged. That way we don't have to ask as many questions. Some of that information is just transferred. You answer surveys such as your diet, your exercise, your family history. Physical measurements are taken, so that is your blood pressure, your weight, your height. You provide biosamples, that is sometimes a buccal swab of your cheek, blood, or urine. And if you have any of these handy dandy little wearable devices, those can also be connected so that we can obtain real-time data. What questions may be asked, you say? Can we develop pain medications that aren't addictive as we are in the middle of an opioid epidemic? Can we develop better treatments for diabetes to prevent diabetes and identify who's at risk and move forward with therapy so they don't develop diabetes? Can we slow or even stop different kinds of dementia? These are the kinds of questions that we hope to answer with this research program. And I ask all of you to consider becoming a part.
The All of Us research program is an ambitious effort to gather health information from 1 million or more people across the U.S. Researchers will be able to use this information to uncover new, more precise ways to prevent and treat disease and to keep people healthy.
If we delve deeper into where we live, what we consume, what we do, that will have an impact on trying to prevent diseases in the future.
Precision medicine will allow us to get the right medicine at the right time for the right person.
Diabetes, high blood pressure, obesity, illnesses that Black women get and die from needs to be researched.
This isn't going to be some sort of Tuskegee experiment. This is going to be the community working together with healthcare institutions.
So what's the promise for those who participate? The goal is that we will fight disease together. You will learn about your own health and perhaps new treatments that are produced each and every day. You'll have access to your own data, but more importantly, you'll learn about additional research opportunities that you can be a part of. So if you're interested, please visit researchallofus.org to learn more. We have in Illinois 5 institutions that participate with us. And very commonly they join us for these sessions to give just a spotlight of what happens when you're on into those institutions. I may be mistaken, but I don't think there's anybody on today from any of our healthcare provider organizations. Nicole, are you on? Well, I would just go through these slides. Actually, I'll go back for a second. These are the institutions that participate locally: Northwestern, Rush, University of Chicago, University of Illinois, and the North Shore. This slide went through a little bit of about what I talked about in terms of the consent process, the surveys, the physical measurements, biosamples, and wearable devices. So I won't go through those again. So if you have any interest in the program, and I hope you do, you can visit any of the sites listed here. You can go to any of our social media platforms, and stay tuned because we're going to have an All of Us pop-up clinic coming very, very soon. Always, you can reach out to me, again, Yvonne Collins, your citywide coordinator. As we prepare to go to the educational portion of our webinar this morning, I must read you this disclaimer. The views and opinions expressed by the guest panelists and/or presenters do not reflect the views or opinions of the Delta Research and Educational Foundation, Draft Research Matters for All of Us, the NIH All of Us Research Program, or any of the organization affiliates. Thank you very much for attending, and I'd like to introduce our guest speaker for the day. I am going to stop sharing, and Dr. Emolefe, you can go ahead and start to share your screen. Nancy Emolefe is a breast imaging radiologist and medical director of the Franciscan Health Breast Center in Michigan. She's a graduate of the University of Texas Medical School at San Antonio, an internship initially in obstetrics and gynecology at McGee Women's, and then internal medicine at Tulane. And she completed her diagnostic radiology residency also at Tulane in Louisiana, followed by a fellowship at Stanford in breast imaging in California. Her passion for women's health led her to initially pursuing a residency in obstetrics and gynecology, which changed to a pursuit of breast imaging. She's an active member of the American College of Radiology and the Society of Breast Imaging. She specializes in the full breadth of diagnostic and procedural breast radiology, some of which I'm quite sure you'll hear about today. And she's passionate about detecting and diagnosing breast cancers at early stages. The dynamic duo, her husband, Patrick, is also a physician, and she has a 4-year-old son. Outside of medicine, she enjoys cooking, group fitness, and Lego building. I remember those days with her son. Without further ado, I give you our featured speaker.
Thank you so much for that introduction. Yes, hello, my name is Dr. Nancy Emolefe. I'm a breast imaging radiologist and medical director at Franciscan Breast Care Center in Michigan City. And today I'm going to be talking to you about breast cancer, specifically what you need to know about early detection. So I'll go into a little bit about what it is that I do as a breast imaging radiologist. So a breast imaging radiologist is a physician who specializes in the early detection and diagnosis of breast cancer. I have a couple of different tools that I use for this. Most notably, you probably heard a lot about mammography. That's this image here. And then there's quite a few other kind of imaging modalities that I also use. So we have breast ultrasound, which can also be used to detect findings in the breast MRI, as well as image-guided procedures such as biopsies. So what I hope you'll learn today, I've sort of outlined here. There are a couple of different points that I'm going to touch upon. First off, I'll talk about the definition of screening mammography, what exactly it entails. I'll also talk about why early detection is important. I also hope to bring some clarity into the topic of screening guidelines and just sort of recommendations around screening. We'll talk a little bit about patients who might require additional high-risk screening why, when, and how that's done. And then we'll talk about your personal risk for breast cancer and factors that might increase your risk. And then we'll touch upon some additional considerations for Black women as it relates to breast cancer and breast screening. So first we'll touch on screening mammograms. I'm sure a lot of you have heard about screening mammograms. A mammogram is a non-invasive X-ray that's used to check the breast for early signs of breast cancer and other abnormalities. So mammograms can really detect cancer very early, typically when it's most treatable, and this can be long before it's ever felt in the breast. If that's able to be done, this could dramatically improve your odds of survival, and it can help you avoid more extensive treatment. As far as just screening mammograms in general, they're considered a routine health maintenance exam. So that distinction is important because you get mammograms, screening mammograms, when you don't have any clinical symptoms, so no lump or any other problems in the breast, and it's part of your routine health maintenance. This is different from a diagnostic mammogram, which is something you would get if you had an active complaint, and we can talk about that later, but that's really beyond the scope of this talk. I'm open to questions about that later, though. So this is just some images of what it looks like to get a mammogram in case you've never seen that. So typically for a standard mammogram, the technologist will position the patient in the mammogram unit. We have our technologist here that positions the breast on the image detector. That's what's shown here. And then there's a compression plate that compresses the breast. This helps to disperse the breast tissue and allows the radiologist to really detect subtleties in the breast. We do typically 2 standard views of the breast, which I'll show here. So these are the 2 standard views that are included in every screening mammogram. So we have this sort of view from the top, and then we have an additional view from the side. So 2 different views from 2 different directions that really allow us to see the vast majority of the breast tissue. So as a radiologist, this is where my job comes in. So I'm the person that interprets the mammogram. So this is what a standard mammogram looks like when I'm interpreting it. This was a patient I saw a couple of months ago. We can see here, this is the right breast, this is the left breast, this is that one view from the top, and then we have an additional view from the side, again, of the right breast and the left breast. On mammogram, some findings can be very easy to see, can stand out quite considerably. This is a patient that had a mass that we can see here in the left breast that I've circled here in purple. But there's also some findings that can be a lot more subtle and difficult to see. So this was that other case I showed you, this was a biopsy-proven cancer. This also, more subtle finding, was also cancer. And it's shown here by just some very subtle little calcifications in the breast. And so that's where screening mammography really comes in. Oftentimes we can detect these really, really subtle cancers that are too small to detect by feeling it yourself or even by your doctor feeling it. So really regular screening mammography really helps us pick up these very, very hard to find cancers otherwise. So I'll touch a little bit upon why early detection is so important. The biggest reason that we stress early detection is that it saves a large percentage of lives. It's been known for many years that mammographic screening is able to detect a large percentage of breast cancers before they can be felt and when they're at a smaller size, earlier stage, and more likely to be curable. So that's extremely important. Early detection also reduces the severity of treatment that women with breast cancer need. So if you're able to pick up these cancers when they're really small, you're less likely to need more intensive treatment like mastectomy or removing the entire breast or even chemotherapy. You may be able to avoid some of those things. And it's also important to remember that breast cancer is not a death sentence and it can be curable, especially if it's detected early and treated early. So there have been so many advancements in breast cancer treatments over the last 30 years, for example, and that often means that patients have higher cure rates, better survival, and better quality of life even after breast cancer. So a big topic of discussion is when should I be screened as a woman for breast cancer? The short answer is starting at age 40. Several major health organizations, including the American Cancer Society, the American Society of Breast Disease, the American College of Radiology, the Society of Breast Imaging, they all recommend yearly mammograms starting at age 40. This has really been shown to prevent the most deaths from cancer and save the most lives. That is when you start screening at age 40 and you continue every year thereafter. And really, as far as how long you should consider continue screening, it should continue as long as you're in good health. They say, as long as you have a life expectancy of 10 years or more, you can continue screening. There's no real limit to that. I've included just some research here about the statistics of why we start screening at age 40. I won't get into all of the research, but just wanted to show this to say that there's a lot of research surrounding this topic. Again, supports the fact that starting screening at age 40 results in the greatest mortality or death reduction, the most lives saved, and the most life years gained. So the Society of Breast Imaging also states that annual screening mammography starting at age 40 reduces breast cancer mortality by 30%. So there has been a bit of confusion about when to start screening and how often to screen. I don't know if you guys have heard some of the different screening recommendations that are out there. I've stated that, my recommendation as a radiologist, the Society of Breast Imaging, the American College of Radiology, we all recommend starting at age 40 and continuing every year. But there are some alternative sort of screening schedules that you may have heard of. For example, starting screening at age 45 or even age 50, and then screening every other year. And really some different organizations have made these recommendations, and oftentimes these recommendations may be dictated by a desire to allocate resources appropriately, a number of different things. But as far as saving the most lives and reducing the risk of death from breast cancer, you really get the most benefit from starting at age 40 and continuing every year. So again, that is the recommendation by radiologists who actually are at the front lines detecting breast cancer. So again, this sort of confusion, there's a large campaign by the Society of Breast Imaging to end the confusion surrounding this. Just to reiterate, again, age 40 and then continuing for every year as long as you're in good health. So a big question again is, what is my risk for getting breast cancer? So in the United States, 1 in 8 women will develop breast cancer during their lifetime. That's about a 13% risk of developing cancer throughout your life. That's 1 in 8. We've heard about different things that can increase your risk for breast cancer. I'm sure a lot of you have heard of the BRCA gene mutation, the BRCA1 or BRCA2. And that's a gene mutation that some women can get that can actually increase their risk of getting cancer up to 45 to 65%. So someone that's popular in the media is Angelina Jolie. She tested positive for BRCA1, and she went on to have a double mastectomy to prevent breast cancer. Aside from sort of obvious gene mutations, there are a number of other things that can increase your risk for breast cancer. So I'm going to touch upon some of those. One of the ones that we may all be familiar with is a family history of breast cancer or ovarian cancer. And that's really in a first degree relative. So a mother or a sister, think of it that way. So again, that increases your risk of breast cancer. But it's also really important to note that most women, more than 75% of women who get breast cancer have no family history whatsoever of breast cancer. So it's very important to not relax just because you don't have a personal family history of breast cancer. Some of the other things that we have to think about in terms of risk is you are at increased risk as you get older. If you've had breast cancer before, you're at risk of getting breast cancer again. If you entered menopause at an older age, you also have an increased risk of breast cancer. If you started menstruating at a younger age, that also increases your risk for breast cancer. Never having had children, obesity, those are other things that can increase your risk. We mentioned BRCA1 and 2. Another important one is a history of chest radiation under the age of 30. For example, if you had lymphoma and had to have radiation treatment for that, that can increase your risk as well. And then having dense breasts is an independent risk factor for breast cancer as well. So that's really the ratio of how much glandular tissue you have in your breast to fat tissue. So the more glandular tissue you have, the higher risk of breast cancer. The more fat you have, the lower risk of breast cancer. So in this case, it's actually beneficial to have more fat, one of the few cases where it's beneficial. And then there are certain other high-risk lesions that you can have after biopsy that would also increase your risk for breast cancer. And I've listed some of those here. So in just thinking about risk, women who have a lifetime risk of more than 20% are considered high risk for breast cancer. I mentioned that the average risk was somewhere around 13%. So if you have a greater than 20% risk, you're considered high risk for breast cancer. So then the question becomes, how do you assess your personal risk for breast cancer? How do you get that percentage for yourself? So I'm going to talk a little bit about that here. There are several different risk assessment tools or risk calculators that determine your own personal risk of getting breast cancer. So I've listed some of them here. The Tyrer-Cuzick is the one that I prefer to use, but there's also several others like the Gale model. Here is just sort of an example of that calculator here. This is the Tyrer-Cuzick. And it asks you a couple of different questions that, again, they'll combine collectively and give you a percentage of what your risk is, your personal risk. So things like your age, your weight and height, which will help you them determine your BMI, the age of your first period, whether you've had children or not, whether you've gone through menopause and at what age, all of those things factor into your personal risk. And then you essentially get a number, and that is your personal risk for breast cancer. So if you actually, I've included a link here, you can actually do this yourself. There are several websites where you can actually plug in that information and come up with a risk percentage for yourself. But it's also important to ask your doctor for a formal risk assessment, something that they can do in office and then have that risk documented, and that can help you then guide your screening recommendations. And I'll talk a little bit more about that. So we mentioned that some people are at higher risk. And we said that that risk is typically a lifetime risk of greater than 20% chance of getting breast cancer. So if you are known to be of higher risk, the recommendations for screening for you are a little bit different than just getting a mammogram every single year at age 40. So if you have a known genetic mutation, so something like BRCA1 or 2, or if you did that calculator model and you have a lifetime risk greater than 20%, then you should actually start getting mammograms at age 30, and then you should continue every year. And you should also get an MRI, which is an additional imaging modality to evaluate the breast. You should get that at age 25 to age 30 and continue every year. So it's really important to know your own personal risk, because you could fall into these categories that require you to start getting imaged earlier and with additional imaging modalities. If you have a history of breast cancer and you have dense breasts at any age, or breast cancer that's diagnosed before the age of 50, you really should be getting both mammograms and MRIs that are done yearly. If you've had radiation to your chest before the age of 30, you should start getting mammograms at age 25 or even 8 years after the therapy, whichever is later. And then you should also be getting MRIs starting at around age 25 to 30. And then if you've had a biopsy before and the biopsy came back as any one of these high-risk lesions, ADH, ALH, LCIS, then you should start getting mammography at the time of that diagnosis, and then MRI as well, continuing yearly. So those are really important. It's really important to ask your doctor for formal risk assessments. So you know that whether you fall into any of these categories that would require additional screening modalities. So another important consideration is how do these recommendations differ for Black women specifically? We know that breast cancer disproportionately affects minorities. For example, in 2010, breast cancer mortality rates were 41% higher among African American women than among non-Hispanic white women. And part of this is due to lower rates of breast screening, but there are also some other factors that come into play. So as far as formal recommendations, the American College of Radiology and the Society of Breast Imaging have issued a joint recommendation that says African American women should really have a breast cancer risk assessment at the age of 30. And that's to determine if they should undergo additional breast cancer screening earlier than age 40. And that you guys saw me talk about that breast risk calculator, for example. That risk assessment is something that should be done at the age of 30 for Black women. And again, this will help guide your doctor to order additional supplemental screening if needed, or start screening at an earlier age if needed. And so why is this? Well, Black women have a twofold higher risk of aggressive or triple negative breast cancers. They also have a higher risk of BRCA1 and BRCA2 genetic mutations than women of Western European ancestry. They're also less likely to be diagnosed with earlier stages of breast cancer than other races, and they're twice as likely to die of early breast cancer. So there are a lot of sort of risks that we have there as Black women. So again, it's really important to ask your doctor for a formal risk assessment if you're a Black woman, at least 30 years of age, and if you think that you might be at elevated risk for any other reason. You should really have this risk assessment so you know if you belong in one of these higher risk categories. Some of the barriers to screening, I just sort of listed these here. In the past, I think we've talked about this already. There's been some confusion about when to start screening, but hopefully I've made that clear that really age 40 is when you should start, and you should consider continue screening every year as long as you are in good health. There's sometimes some general concerns about radiation and the radiation that's associated with mammography. It's important to know that mammograms have very low doses of radiation. Just for comparison, you get 8 times more radiation from the natural environment that you live in within the course of a year than you would from a single mammogram. So that just living and existing in your normal environment, you actually get more radiation from that than you do from getting a mammogram. Some people worry about the discomfort of a mammogram, and yes, it can definitely be uncomfortable, but you sort of have to weigh the benefits of getting the mammogram and detecting any findings or abnormalities early if they're there. Some people worry about getting a scary result or having to be called back. And of course, getting a mammogram, increases your risk of having to be called back if there is an abnormality. But again, the earlier you can find something, if it exists, the earlier you can be treated, and the better your outcome. So that's also something to keep in mind. And then there's also this worry about needing a biopsy. And it's very possible that you could get a mammogram, you could have an abnormal finding, and then your doctor or the radiologist might recommend a biopsy of that finding. But it's important to remember that most biopsies that we do as radiologists are really minimally invasive procedures. They're very well tolerated. Actually, I had a patient just last week fall asleep during one of the biopsies that I did for her. So generally people do very well with them. So that shouldn't be a significant concern. And then sometimes you might think that you put off screening too long and that it just might be too late, but it's never too late to start screening if you've never had a mammogram before, or if you've sort of fallen behind and haven't had one in a while. It's always better to get back in there than to put it off even further. So just sort of to recap and to go over what you can do now. So again, I've stated yearly mammograms are very important starting at age 40 if you're of average risk. And again, this offers the best chance for detecting cancer early and identifying any changes in your breast year to year that could signify an early cancer. It's important to talk to your doctor about a risk assessment. So this might mean that you should start breast cancer screening even before the age of 40, or that you might need additional supplemental screening with something like a breast MRI. And that's if your lifetime risk for breast cancer is more than 20%. And then it's also important to just be familiar with your own breasts so that you understand what's normal for you and that you're aware of anything that changes, and you can promptly report any of those changes to your doctor and have us as radiologists evaluate them as well. And then there's also some lifestyle modifications that we should all consider to reduce our risk of breast cancer. So things like reducing your weight. We know that being overweight or obese is a risk factor for breast cancer. Increasing your physical activity, drinking less alcohol, reducing alcohol intake, and then avoiding hormone replacement therapy, especially if you're postmenopausal. We know that that's a risk factor for breast cancer. Breastfeeding longer if you have children is also really important, but there are a number of things that you can do also to decrease your risk of breast cancer. So also keep those in mind. And that is all I have. Just want to stress again, early detection saves lives, and I'm open to any questions that you might have.
Thank you, Dr. Molefe, for a fantastic, thorough presentation. As we prepare for questions, you're going to see in the chat box momentarily a link that takes you to our survey. This is the beginning of our 21-22 calendar year for Draft All of Us Research campaign educational seminars. So we want to make sure that you are enjoying these, that you're learning from them, if there are things that we can do to make it better. So please complete that survey once it's in the chat box, and it will be there momentarily. We do have a few questions. The first one was related to COVID vaccination and lymph nodes prior to mammogram. There's been a lot of talk about when you get your mammogram compared to your COVID vaccine, how the COVID vaccine causes some discrepancies in your mammogram. Can you talk about that?
Yeah, that's a great question. And we've seen a lot of that since the COVID vaccine kind of came onto the scene. The biggest thing that we see when people get COVID vaccination is an increase in the size of their lymph nodes. And this is typically on the side where they were vaccinated. So for example, if they got the COVID vaccine in the right arm and they get a mammogram shortly thereafter, we might see abnormally enlarged lymph nodes on that side. Now, the problem with seeing lymph nodes on mammography is sometimes lymph nodes can be an indication that a cancer is present. So it tends to confound the picture, right? So one of the things that we recommend and have implemented is as far as the COVID vaccine, it's fairly normal to see abnormal lymph nodes probably within about 3 months of getting the vaccine. So if you get the vaccine, you can have abnormal lymph nodes in your armpit for up to 3 months. So if you've had the COVID vaccine and you get a mammogram shortly thereafter, we might make note of the fact that there are some enlarged lymph nodes, but oftentimes if you've had the vaccine recently, we might say it's likely due to vaccination, and we'd recommend a follow-up to make sure that those lymph nodes normalize. So it's possible if you want, if you can schedule your mammogram, you can always schedule it far, so that it doesn't coincide with your COVID vaccination. But if there's that sort of confounding issue, we always follow up those areas to see if that finding resolves over time. If it doesn't, again, that could mean that there is cancer in that lymph node, and that would require further evaluation, sometimes additional ultrasound imaging or even biopsy. So yes, that's a great question. It's something we've seen quite a bit.
Just a follow up to that, and you may have answered it while you were speaking, those lymph nodes do go away. Can you talk about how soon they go away?
Yeah, so they should resolve within 3 months of your vaccination. So if you get a COVID vaccine and 3 months later, you still have abnormal lymph nodes, we start to worry that something else might be there, like cancer, and that this is not necessarily secondary to the vaccine. So we expect that they go away around 3 months. Sometimes it can be a little bit longer, 3 to 4 months. But if we see lymph nodes that are persisting after really that 3-month mark, then we start to do additional investigations to rule out there being cancer there. I don't know if that makes sense.
It
Is that
does.
clear?
Yeah, thank you. Can you talk a little bit about your opinion of self-breast exam and how beneficial they are?
Yeah, that's a really important topic. I think a lot of the major organizations are moving away from recommending self-breast exams, even though that's something that has frequently been recommended in the past. And the reason is that they've noted that self-breast exams tends to do more to increase what we call false positives. Rather than self-breast exams, what we're recommending now is just general breast awareness. So just being kind of knowledgeable about what your breasts look like and feel like, and if there's any sort of abnormalities that you can detect, but not necessarily doing monthly breast self-exams. The reason we're sort of shying away from the self-breast exams is that I think in the past, we've had a lot more women coming in with findings that end up being negative ultimately, and increases the amount of workup and biopsies for things that end up being negative. I don't know if that makes sense, but general breast awareness is what's preferred over sort of routine monthly breast exams.
Just a follow up to that, because I'm quite sure the ladies are wondering. So when you say breast awareness and things you should look for, give us a few of those things. What should they be looking for?
So there's quite a few things. So if you notice any, number one, skin changes in your breast, areas of like dimpling that weren't there before, if you notice any changes in your nipple, sometimes you can have, there's some sort of eczematous changes of the nipple or chafing that can be an early sign of breast cancer. Lumps, those are sort of the classic things. If you feel a new lump or you come across a new lump, say in the course of showering, something that you didn't feel before, that's another reason to come in. Nipple discharge is another thing. There are certain kinds of nipple discharge that are more worrisome than others. So if you have bloody nipple discharge or even clear nipple discharge can be something that you need to have evaluated. So those are sort of the major things. Lumps, skin changes, nipple discharge, and then just sort of nipple changes in general.
One thing I'll add to that, that I just want to make sure people are cognizant of, if your nipple starts to go inside, so a retraction of the nipple or retraction of the skin of the breast, that's just another one I just want to add on there that you just want to make you aware of.
Yeah. And it's possible that some people, have had nipple, what we call, nipple going inside or nipple inversion, and that's been a finding that's been stable their entire lives. But when it's a new finding or something that's a change from what was normally there, you should definitely start to worry and get that evaluated.
Absolutely. Thank you. The next question is, are you able to give a percentage of women of color that are diagnosed with a triple negative breast cancer before age 40?
Oh, before age 40. It's certainly higher than the European, Western European population. Before age 40, I want to say somewhere around 15 to 20%. I can get hard numbers for you, but I'm sure it's within that range of those that are diagnosed before 40.
Okay.
Because I think women who tend to have cancer before age 40 tend to have more aggressive subtypes, unfortunately.
Right, absolutely. The next question, you talked about screening, but one thing that the guest said they didn't see is, what if there is a cancer in your family? Does that change that screening cycle?
Yeah, so that's one of the things that I was, I guess, trying to impart with the risk assessment tool. So if you have a personal family history of breast cancer, especially in a first degree relative, you should have a formal risk assessment. And part of that risk assessment has questions about that. For example, do you have a mother or a sister that's had breast cancer, and at what age? And all of that factors into this kind of holistic risk assessment. Oftentimes, if you've had that history of a first degree relative with the breast cancer, that's going to increase your risk dramatically, sometimes above that 20% threshold. That would put you in the category of needing higher risk screening examinations. So, screening before age 40 and then a breast MRI. So it's sort of incorporated in that holistic breast assessment. It's not really just the family history, but it's everything together. So your age, your BMI, the family history, that gives you that holistic number. And then you could then be able to tell whether you fall into one of those higher risk categories that requires additional screening.
Thank you. The next question, on the last slide, there was a precaution about avoiding oral contraception. Is birth control known to increase your risk of breast cancer?
Yeah, so it's more so hormone replacement therapy. That's the one that I was trying to stress a little bit more. Hormone replacement therapy after menopause. There's been some studies that have suggested maybe some minimal increase in breast cancer from oral contraceptives, and then the others that have countered that. So I think that the jury's not completely out. It's the current consensus is that it may increase your risk for breast cancer minimally, but hormone replacement therapy in a postmenopausal woman, that's the one that's a little bit more of a significant risk.
Thank you. And the last question I have, and if anyone has a question and they didn't put it in the chat, feel free to raise your hand and I can unmute you. The last question officially that I have is, a lot of times when dense breasts are found on mammography, there's a recommendation for follow-up ultrasound. Can you talk a little bit about that, and do you have an opinion?
Yeah, so that's a really, really important question. So mammography is an excellent screening modality. We talked about the importance of screening at 40 and getting screened regularly, but mammography is not as good in certain patients as it is in others. For example, the more dense your breasts are, the more difficult it can often be to find certain abnormalities in the breast. We've heard about things like 3D mammography, which sort of increases your ability to detect abnormalities even in dense breasts, but still mammography is much better in someone who has less dense breasts and someone who has dense breasts. So oftentimes for patients who have extremely dense breasts, there might be a recommendation for additional screening with other modalities, just because it's very difficult to identify abnormalities in breasts that are very dense. So one of those modalities is breast ultrasound. So you can have a screening ultrasound that is just another screening modality to detect findings in the breast. It uses ultrasound as the imaging modality of choice. There's also breast MRI that sometimes is recommended as another sort of supplemental screening for patients with dense breasts. So that's definitely a conversation that you can have with your doctor if you have been told that you have dense or extremely dense breasts. And it's definitely something that can supplement your routine screening mammography if you are in that category.
Thank you very much, Dr. Emelefeh, for answering questions. Are there any last minute questions? I don't see any hands up. I don't see any in the chat. In case you do, I'll give you a moment. Pastor Kay, would you like to give some comments on behalf of DREF?
Yes, Good afternoon, everyone. I am Reverend Dr. Kay Williams Dawson, the Community Engagement Coordinator for the DREF Research Matters for All of Us initiative. And on behalf of DREF, Executive Director Cheryl Thomas, and the entire Research Matters team, I thank all of you for joining us in this critical and most important research webinar about breast cancer awareness. I definitely want to thank Dr. Yvonne Collins, our Chicago citywide coordinator, and her team of volunteers, our guest speaker, Dr. Nancy, the Illinois 5, our HPO providers, and everybody that's in attendance for tuning in. Dr. Nancy had mentioned about the BRCA1 and 2 gene. And so I just wanted to give you a little information as it pertains to the DREF research project that we're doing. Because the development of breast and/or ovarian cancer is associated with the mutations of both BRCA1 and 2 genes, and it is important to know our family history. Sometimes that genetic testing is necessary, and we have found that it can cost up to $2,000. But the All of Us research program does it for free. And so for more information about the All of Us research program or the free genetic testing offered, please feel free to visit joinallofus.org/DREF. Again, thank you all so much. And I will now turn it back over to Dr. Collins.
Thank you very much, Pastor Kay. Thank you all for attending. Hopefully everyone has finished their survey. If not, please complete your survey. I just wanted to highlight our November events, so I hope you come back and join us. On November 20th at 12 noon, we're going to be talking about skin health with Dr. Patterson, and hopefully in partnership with the Chicago Skin Society. And then November 22nd at 6 p.m., we will do diabetes awareness with Sue He. Anyone that perhaps joined us last year, they did an absolutely fabulous presentation on diabetes, and we actually did some relaxation techniques. So feel free to join us. Thank you all very much. If by chance you found our webinar in a different aspect, feel free to put your email address in the chat box, and I'll be sure to keep you updated on all of our events. Again, thank you very much for joining us. I hope you gathered one nugget today, and everybody continue to mask up and get vaccinated if you have not. Have a great rest of your Saturday. Thanks for joining us.